Yes. It's a great pleasure to introduce Dr. William Reichman, our speaker today. Since 2007, Bill has been president and CEO of Baycrest, the U of T affiliate familiar to most of us as one of the world's great geriatric research and innovation centers, and as a health and residential care provider. With its focus on cognitive neuroscience, dementia, and more generally brain aging, it's not surprising that Baycrest turned to Bill to lead its multifaceted operations. He is a psychiatrist. He's professor of psychiatry in our Faculty of Medicine, whose research focuses on geriatric mental health. And he is as well an experienced academic administrator. He's also well known internationally as a consultant on healthcare for seniors, the subject of his talk today. In his spare time, Bill serves as president of the International Psychogeriatric Association, as chair of the Seniors Quality Leap Initiative, a collaborative of US and Canadian elder care organizations, and as president and CEO of Cognicity and of Baycrest Global Solutions. He's former president of the American Association for Geriatric Psychiatry and the Geriatric Mental Health Federation. He's also played a leading role in developing Canada's national dementia strategy and in its implementation. And we're especially grateful to Bill for agreeing to talk to us on such short notice when previously scheduled speaker withdrew. His topic today is innovation and the coming transformation in seniors healthcare. Please join me in welcoming Bill Reichman.
Thank you. Thank you so much, Brian, and good afternoon to my fellow U of T faculty members. I wish only that my mother was here to have heard Brian's introduction. She lives in South Florida. But as Brian said, my expertise is largely in the area of aging and brain. But over the years, my academic and related interests have moved away from earlier career interest in the development of drugs to treat diseases like Alzheimer's disease, and more into how we're actually caring for people suffering from aging brain-related disorders. And that got me much more in recent years interested in health services and the character of care, both in congregate care settings like nursing homes and retirement homes, as well as how people are being evaluated and cared for in the community. And as I got more immersed in how care is or isn't being delivered effectively, I became more interested in those global trends that are likely going to influence the care of the future, because I'm of the baby boom generation. I was born in 1957, the peak of the boom. Most of what we are going to have to deliver in the years to come will be to aging boomers. The first cohort is now starting to access senior care services. And what's become very clear from surveys of baby boomers across developed nations is that we will not tolerate the approach to our support and care that our parents and grandparents were forced to accept. And so we are going to push hard for transformation. And in fact, it's already occurring. So I'm going to talk today about what I believe are some of the most critical trends that are converging that will shape the future of healthcare. And because of my interest in today's topic, I will focus on the care of older adults like myself. I won't say any of you, but myself, and what the implications are not only for older adults, but for broader healthcare delivery, largely across, for now at least, developed nations and the Western nations, including, of course, Canada. For better or for worse, some of what I'm going to cover inherently is controversial in terms of whether these trends are actually ultimately good things or bad things. And I set the talk up intentionally for that reason, so that it could provoke conversation. So I'm going to do my best not to talk at you for this entire session. I've got probably about 40 minutes of content to cover, and then I'm hoping that we can engage in an interactive conversation to address your questions, but I'm also very interested in some of your editorial comments, because I do understand, if I've got this right, you do represent quite an eclectic and interdisciplinary group of thinkers, right? You're from different faculties. And so those of you who are from the life sciences or biological sciences may have a different take on some of what I'm going to present than those of you from the social sciences. And I think, coming together to discuss some of these trends and what they might mean for society could really be enriched by such an eclectic group of thinkers. So let me now do my screen share and we can get moving. Okay, I'm going to assume that that everybody can see this first slide. Okay,
They're
Brian,
fine.
Yep, they're good. Okay, so off we go. So we're going to be covering the topic of innovation, and what I believe is the coming. It's sort of arriving now, given the impact of the pandemic on catalyzing some of these trends. But I'm going to talk about innovation and the coming disruption in the way in which we deliver healthcare and related supports to an aging global population. Now, this sector is particularly ripe for innovation. As I alluded to a moment ago, the boomer tide, of which, again, I'm a seminal member, is creating significant demand for new approaches that support choice in care. So while our parents and grandparents, once they reached a stage of sufficient physical or cognitive frailty, or some combination of both, had only a nursing home as the available option, this is rapidly changing. When an older adult was suffering from an acute episode of pneumonia, the only option was to go through an emergency department and then get admitted to the acute care hospital. That is rapidly changing, as we're going to talk about in a few minutes. Innovators, investors, and a wide multitude of industries are seeking opportunities in the longevity economy to create wealth. And the private and public sector healthcare payers are looking for more value creation. Healthcare in certain countries, including most critically here in North America, healthcare is one of the most wasteful of sectors in terms of getting value for the dollars that are being spent. And we're going to talk about how payers are now addressing that, particularly on the public sector side, since today we're in Canada, not in the United States, and what this could portend for what healthcare delivery looks like, not only in Ontario, but across Canada moving forward. So innovation has become such an overwrought and overused term that I wanted to give you the broadest possible concept of what I'm going to mean by innovation, because I'm going to talk about it in several different contexts and how innovation is occurring in a variety of different ecosystems and then converging on how it will impact our lives, particularly in terms of getting healthcare supports. So for the purposes of this talk, I've chosen this definition, which is quite broad. Innovation represents the design, the invention, the development, and/or the implementation of new or altered products, services, processes, systems, organizational structures, or even business models, all for the purpose of creating new value for consumers. And in this talk, the consumer is largely going to be the individual seeking healthcare support, and the payers that provide the funding. Now, I can't talk about all the different trends this afternoon. That could be a week-long course. But I am going to settle on a couple of trends that I think really are the most heavily weighted in terms of what the future is going to look like for us, in terms of what we can anticipate in the future of healthcare delivery. I'm going to focus on big data, the application of artificial intelligence, and the Internet of Things. By big data, I largely will be referring to those large data sets that can be analyzed computationally, that reveal patterns or trends, that especially in this context relate to human behavior and human interactions. By AI, I mean computer software platforms that are able to analyze very large data sets and then do with the data something approximate to what the human brain is able to do in terms of things like visual and facial recognition. But importantly, in this context, being able to engage in decision-making that approximates the human brain's capabilities. And then by the Internet of Things, which we'll also reference, largely what I mean is the connectedness between different objects that then feed data into a cloud-based analytic platform. That data then used for a variety of different purposes. Again, the context here is going to be informing healthcare decision-making and the delivery of healthcare. We're also going to talk about the rapid emergence of virtual medical technologies. And some of these advances have really been accelerated by the requirements of the pandemic. One obvious example is virtual healthcare delivery or remote healthcare delivery, where it was critical in order to maintain physical distancing, prevent the spread of contagion, for patients to be able to access medical care without physically going to a hospital or to a doctor's office. And I would suggest that if there's any lemonade to be made out of the lemons of this horrible pandemic, it's the acceleration of the application of virtual care. It was coming anyway, but it is really now exponentially increasing in adoption and implementation. The other trends that we're going to talk about as they converge with the big data and virtual medical technology advances is transformation in the way in which healthcare systems are operated, how they function, and thus how they're structured, because by and large, structure follows functioning. And then there's another trend that is also occurring where patients are increasingly demanding of their healthcare systems and are taking a consumer mindset to healthcare. Again, by way of comparison, our parents, and most certainly our grandparents, were very passive recipients of healthcare. The doctor told them what was wrong with them. The doctor told them what needed to be done, and they followed that advice. The doctor was in charge. There was no doubt about that. And as we're going to talk about in a few minutes, the doctor and the hospital, the clinic, were the stewards of the healthcare information. It was the property of the healthcare provider, and the patient had to ask for permission to see their medical records. You can see that, and I'm sure this is true for many of you who perhaps are now accessing my chart. You can see that this trend is now accelerating, where we're going to own our medical records, not the healthcare provider, as patients, and we're going to get access to every bit of information that we're interested in. And I'm going to get to that in a few minutes. And then finally, there's another related trend to the consumerization of healthcare, which converges with some of the technological innovations, which for this talk, I'm going to call the retailization of healthcare. And I'm going to give you some examples of what that might look like going forward in Canada, as exemplified by what's happening in some other nations where it's a little further along. So these are the four main areas of innovation that are going to inform this talk. So those of us who are engaged in healthcare planning, and I should disclose that I do advise the government of Ontario quite a lot on a healthcare system transformation. I advise the government of Canada on policy as it relates to aging. And I also do advise the World Health Organization and the governments of the United States and the central government in Beijing, China, on healthcare policy as it relates to these trends and what it could portend for these different jurisdictions going forward. So much of what I'm going to share with you, I have shared with policymakers and with payers, particularly on the public sector or government side. Those of us who think about how best to meet the needs of older adults, we may put some variation on this theme, but by and large, it still respects a Maslow's hierarchy of needs. And that is, in caring for an aging population, when we think about the wellness and safety, the well-being of older adults, we most assuredly have to ensure that public policy supports that the physiological needs of older people are met, and that includes, living in an environment where they have access to food and shelter and clean air and safe water, that they have enough resources to be able to clothe themselves appropriately, particularly during hostile seasons like the middle of summer or the middle of the winter. So the basic physiological needs have to be part of any healthcare planning and healthcare delivery today and in a transformed system. And then, of course, hierarchically, we must ensure the safety of older adults, because as older adults age and become more physically and cognitively frail, they are then at increasing risk for violations of their personal security and safety, both physically, financially, illegally, and otherwise. We need to make sure that there are adequate resources that are marshaled to support older adults. And of course, as we're going to talk about today, all of these things are related to health. One thing I'm not going to be able to say very much about today is the following. If an older adult doesn't have a safe and secure place to live, or they can't access transportation when they need it, or they don't have the money to be able to pay for those things that the healthcare system doesn't pay for, like nutritious food, or some of the healthcare needs that are not covered by present benefit plans like OHIP, then it doesn't matter how sophisticated the healthcare system is in terms of using technology and anything else. If these most basic other things aren't addressed, then we're wasting a lot of time just focusing on healthcare. And this is one of the biggest problems we have with policymakers, both private payers, but particularly public payers, is they look at the issues of an aging population in silos. So the Ministry of Finance looks at the aging population with one set of glasses. The Ministry of Health looks at it from another. The Ministry of Aging looks at it yet from another. And the Ministry of Transportation looks at it from another, et cetera, and rarely do they come together with a coherent, comprehensive, integrated plan for how we will collaborate to meet the needs of our aging population. It's addressed in silos, not only here in Canada and most certainly in the province of Ontario, but in the jurisdictions that I mentioned that I advise, whether it's the United States, China. The only place where I do provide advice and consultation, where there's a much stronger emphasis on linking all these things together, is at the World Health Organization and the United Nations, and perhaps that there's no surprise there. All right, so as we move beyond.
Sorry about this, Paul. And here's the other Paul. Okay, hope to see you in a minute.
Okay, thanks, Daphne. Okay, so and then again, it's probably self-evident to all of you that no matter how aged we get, and in fact, no matter how frail we might get, we still are entitled to the fullest degrees of respect. We should have every available means to continue to support our own self-esteem. We should retain our status. We should be recognized for who we were, who we are, and who we can always continue to be. And we need to have the freedom, wherever it's possible, to have autonomy. We will accept, as we get older, that we might become more dependent on other people for our physiological needs, our safety needs, and perhaps even promoting and pursuing our ability to have friendships, be intimate, stay connected to our communities and family. We may need help with all of that if we reach a sufficient state of frailty. But despite needing help in some way, becoming somewhat dependent on others doesn't mean that we should automatically lose autonomy. And that happens all too often. As we gain frailty, all of a sudden we start to lose autonomy, as if autonomy and dependency are the same, and loss of dependency are the same thing, and they're not. And then finally, and I think this is so critical, is all of us desire, at the top of the Maslow hierarchy, to look back on our lives at some point and say, when we look in the mirror, I self-actualized. I became the most that I could be in my life, in my career. I had the opportunities that I needed to have to achieve and to feel about myself what I always hoped I could. And I have few, if any, regrets. I don't have a slide for it, but I'm going to share with you Baycrest's vision statement. So Baycrest's vision statement, because all the different ways in which we try to support older adults and advance our field through scholarship and research, et cetera, is that every older adult, no matter where they are, should be given the opportunity to live a life of purpose, inspiration, and fulfillment. And since I've come to Baycrest, I have been shocked at the opportunity that still exists for some of the most frail people who at a glance you would say, oh, come on. I mean, how is this person going to really have any further purpose in their life? How are we going to help them be fulfilled? How are we going to inspire them? Because they're so physically frail, they're so cognitively frail. But I've been personally inspired by the ability of the Baycrest staff and for staff in this field and other places beyond Baycrest to be able to achieve what I spoke to, that no matter how frail you are, there is always an opportunity for you to have purpose, to be inspired, and ultimately to be fulfilled. All right, so now let's get into some of the substance of these innovations and how they may disrupt and craft what the future of healthcare delivery, healthcare supports is going to look like. So we're going to start now with healthcare delivery disruption. So with the aging of the global population, it's become increasingly clear that there has to be a shift in focus from so much emphasis, so much resource allocation from the acute and long-term management of chronic illnesses like heart failure, diabetes, pulmonary problems, orthopedic, arthritic, rheumatological problems, and their associated disability, to really promoting wellness, health promotion, prevention. Much more of an emphasis on prevention in terms of resource allocation, aligning incentives for healthcare providers in terms of how they're getting paid is really going to continue to shift from management of chronic illness and disability to how effectively healthcare providers, whether it's hospitals, whether it's primary care providers, whether it's specialists, how well they can demonstrate for the patients that they serve, they have effectively promoted and established the achievable levels of wellness and prevention that are possible for their charges. There will continue to be throughout organized healthcare systems in the developed nations a commitment to the IHI quadruple aim. This is number one in the top right quadrant, achieving better health outcomes in a more cost-effective way. That's the second right lower quadrant, lower cost of care. Improving in the top left-hand quadrant, the patient experience. Not only should the patient get well, but the patient's experience of healthcare delivery needs to be optimized. And I think many of you would share my observation that we make it way too hard for patients to have a positive experience. Are there exceptions? Of course there are, but there are also many barriers that create an experience for patients, whether they're lying in a hospital bed, whether they're trying to get to see a specialist, whether they're trying to get their different doctors to communicate effectively with one another. There are just too many challenges, too many stresses that an already needy person has to face because of the way in which our healthcare system functions and how it's structured to continue to support dysfunctionality. So much more of an emphasis, not only on better health outcomes at the most cost-effective price, but also improving the overall patient experience. And I think in recent years, what had been the triple aim with those three quadrants has now become the quadruple aim. And that is, if we truly want to improve the patient experience, if we truly want better health outcomes, and we want to do it in a more cost-effective manner, then we must improve the experience that staff who are healthcare providers are having in participating in our healthcare system. And I think that you're likely, like me, reading about this right now as it pertains to the pandemic. The pandemic has put remarkable stress on healthcare providers, as it has on all of us in society in so many different ways. But what we are seeing now, which should be quite troubling to us, is the lack of supports for the healthcare worker are leading to many healthcare workers prematurely retiring. Or if they were on the fence, they're leaving now, when in fact they might have stuck it out as healthcare providers longer. And we're quite concerned about this, that the stresses of the pandemic have exacerbated pre-existing tensions that healthcare providers have been having, and it's accelerating their exit from their professional disciplines. Now, you know as well as I that by and large, your healthcare provider here in Ontario and across much of Canada, as well as certainly in the United States, is largely paid on a volume basis. So the more the doctor does, the more the doctor bills OHIP, the more the doctor gets paid. That is generally, based on every available study, not going to help us get to that quadrant and the quadruple aim of cost effectiveness. Also, there are significant problems with regard to doctors' concerns about liability. And so, particularly in the United States, where this has been an abysmal problem, doctors tend to overorder. They order a lot of tests, they do a lot of different things, and part of that is a strategy towards risk mitigation to make sure that there are no claims against them if something goes wrong. Again, in certain jurisdictions, particularly in the United States, there's much more litigation around medical malpractice claims than here in Canada. So that's maybe a good or bad thing depending on how you feel about it, and we can talk about that later. But clearly, what this government on Ontario, governments across Canada, governments in Western Europe, and increasingly in the United States with the development of accountable care organizations, is a shift from volume-based payment methodologies, the more you do, the more you get paid, to patient health outcome methodologies, meaning the better you do as a doctor at a hospital or a healthcare system, the more you're going to get paid. And it's not only going to be how well you relieve a disability in an acute episode of illness. It's really going to be how well you have demonstrated on a population basis that you've encouraged sufficient healthy behaviors that you've gotten to a better health status for your patients. And so I think moving forward with the Ontario health teams, because this is what's going to impact those of us who live in Ontario most directly, the payment methodology is going to ultimately move from volume-based, which is still largely where it is right now, to what are called bundled payments, meaning if you're having a hip replacement, there'll be one payment to the hospital that will pay for the surgeon, it'll pay for the hospital stay, it'll pay for all the imaging and other tests, but it will also then pay for, once you've left the hospital, for your physical therapy, perhaps for some home care that you may need until you're up on your feet again. So all of the different services attendant to that procedure of a hip replacement, there'll be one payment, and then that payment will be distributed to all the different professionals who are involved in your care. That's called a bundled payment methodology. That's already in place for certain kinds of procedures here in the Ontario health system. We are going to evolve, though, from bundled payments to what's called population-based risk contracting. So as the Ontario health teams mature, there are going to be health systems, which we're going to talk about in a moment. Those health systems, which include hospitals, specialist doctors, primary care providers, rehab facilities, home health agencies, they're going to be responsible for a certain population that would generally access their services based on geography or specialized need, like high-risk obstetrics. And that healthcare system, what we're calling an Ontario Health Team, is going to be paid in advance to take care of this population that they're responsible for. And so when that population has to access healthcare, like go to the hospital for a health outcome that could have been prevented, the cost for that's going to come out of the advanced payment that the health system had for keeping you well. So the hospital is going to be, the health system is going to be financially incentivized to keep you away from high cost or high volume services that were preventable. Now, of course, what we're going to have to ensure in systems like that is that you're not denied care that you need based on the health system trying to control cost. And there are examples in HMOs and more mature health systems, like in the UK, the National Health Service, on how that gets accomplished, which some of you are probably much more expert at than I am if you're a health economist or in the social sciences, you look at health system performance. So anyway, I just thought that it was important for you to recognize that. We are seeing clearly the development of integrated health systems, both vertically and horizontally. That's already occurring with the creation of Ontario health teams in Ontario. But quite frankly, some of you, if you get your healthcare in Toronto from one of the major hospitals or a doctor associated with one of these hospitals, you can already see that this is happening. So examples, When you have acute care hospitals merging, it's a form of horizontal integration. So the Toronto Western being part of the same system as the Toronto General, or St. Joe's here in Toronto being part of the same system as St. Michael's. So that's a form of integration where providers at around the same level of addressing acuity come together, so to try to achieve economies of scale. And home health care providers start to merge. Those are examples largely of horizontal healthcare system integration. Vertical integration largely means putting together the entire continuum into one system. And that's the direction Ontario health teams are going. So the highest acuity needs are met by an acute care hospital, and the lowest acuity needs are met perhaps by a home health agency, where PSWs, private companions, help keep a person safe and well in their house. And then there's everything in between: the primary care doctors, the medical specialists, and medical day programs, long-term care, residential-based healthcare, like in retirement homes. But the point is that all of these different parts of the healthcare continuum are joined together under one organizational functional framework and one organizational structure, perhaps with some kind of shared governance and shared accountability agreements, with, again, the funding being controlled at the very top and then distributed on a population basis, like a capitation model where the hospital gets paid a certain amount of money per month per member of the population to keep them well and to service their needs. What we're also seeing, again, is the creation of what are called medical homes. This is, again, the recognition that for the care of the elderly, often multiple different kinds of professionals need to be involved: physical therapist, nurse, a social worker, primary care doctor, cardiologist, rheumatologist. And so what we're seeing is the evolution of what are called the medical homes. One version of this, an early version of this in Ontario, was the family health team. Perhaps some of you have been enrolled in family health teams. And this is essentially team-based healthcare led and coordinated by a primary care provider. This, I believe, is here to stay and will become more formalized as these integrated systems that take hold and the payment methodologies then align with the new functionality and organizing structures. And I think importantly is that the patient, it's at the center of the patient's needs. The care plan is interdisciplinary, it's coordinated, and it's all about what the patient needs, and critically what the patient says is important to them, not what we tell them is important. We inform their thinking, but they're the captain on this ship, not the doctor. There's going to be a profound change in what an acute care hospital is. Right now, by and large, with few exceptions, Ontario hospitals still represent a 1975 version of what an acute care hospital should be. And in Beijing and in the major cities of China, the acute care hospital, even brand new hospitals that are being built, represent a 1965 model of what acute care hospitals need to be, except with 2035 technology. But the service delivery model is obsolete in China, but they're trying to blend an obsolete service model with the latest technology, as if the latest technology overcomes the obsolete service model, and it most certainly does not. Gadgets will never replace thoughtful service delivery. So this still remains a problem in several jurisdictions. Here in Canada, we are still very reliant on the acute care hospital for things that other jurisdictions figured out the acute care hospital no longer has a place in, because it's just not cost effective, it's wasteful, it leads to backlogs in operating rooms specifically, and waits for service. I'll give you an example. There is absolutely no rationale except for in a very high-risk patient, which is rarely the case for routine colonoscopy screening. There is no reason whatsoever that colonoscopy screening should be provided in acute care hospital imaging suite or interventional suite. It makes no sense at all. It's way too expensive because the overhead of that acute care hospital is leveled on that service. The acute care hospitals can't do the kind of volume to really ensure quality that can be done in ambulatory settings. So, without pulling you guys and torturing you with the weeds here, there's going to be profound changes in acute care hospitals. They're going to get smaller, and they're going to be essentially critical care units. So acute care hospitals are going to have less beds per facility. They're going to focus almost exclusively on only those things that can be safely done in a hospital. And that's critical medical and surgical care and the highest risk surgical and interventional procedures. All other surgeries, and this is starting to are going to be same day surgeries to the extent possible, even short stay surgeries for a few days. All of these procedures are going to be done in satellites of the healthcare system, but it's not going to be done you're not going to go to the Toronto General Hospital or St. Mike's or Sinai or Sunnybrook for procedures that can be safely, more cost effectively delivered, probably with better outcomes out in the community, where we can ensure much better access without tying up the operating rooms for what we really need the operating rooms for, or the interventional cardiology and other suites for what we really need those for. And hospitals will, of course, still need to be the place for high-level trauma and life-threatening emergencies. If the emergency is not life-threatening, you are not going to be going to the new emergency department at Sinai Health System, at the Mount Sinai Hospital. You're going to be going increasingly to an urgent care center very close to home where you can walk in, be seen quickly, and not be queued up because the emergency department is so backlogged because they can't move the stretchers upstairs to the patients who need to be admitted. That right now is the reality of the Ontario healthcare system. You could have a rather routine problem that does need to be seen in an emergency department, but you have to wait because that emergency department is backlogged with patients that really need to be hospitalized. You don't. You just need to be seen. And this is insane that you being seen in a cost-effective and timely and patient-centered manner is held hostage to the hospital issues upstairs in the building. It just doesn't make any sense. So this is going to change in my view. All right, so surgical and interventional procedures are going to be the exclusive domain of specialized high volume ambulatory facilities. These will be formally linked to these integrated hospital systems. Perhaps some will be proprietary outside of the public sector, but most will be part of the public sector. What we're starting to see also is so many patients that we thought had to be hospitalized, particularly older patients, particularly with the advent of technology, can be treated successfully with an acute episode of illness at home versus the hospital. They can be triaged perhaps in an emergency center, but they can be sent home with full-time medical surveillance and coverage, both with nurses who are there around the clock, other aides. We can bring in the physical therapist, and you can be remotely monitored at a central location like the hospital in terms of all of your vital signs and everything else that needs to be monitored. And what's being demonstrated, particularly in the United States now, is that these patients not only can be treated in a more cost-effective manner, they have better health outcomes, less medication administration errors, less falls, and less hospital-acquired infections, less medical errors. So I think we are going to see much more of the hospital-at-home concept in the future of healthcare transformation here in Canada. We're already seeing urgent care walk-in centers popping up all over the place. That trend is going to continue, but I do think they're going to be much more formally linked with a continuous system of care. They share the same medical record as the rest of your healthcare providers, which right now they don't, unless they're operated by a hospital, which several are. And we're going to continue to see the exponential growth that was catalyzed by the pandemic in virtual healthcare delivery or telemedicine. Another trend that is emerging is, again, the patient's mindset as that of consumer and the associated retailization of healthcare. So the patient is consumer. Our generation of baby boomers are going to expect that healthcare will be delivered in the most convenient manner, time and place for us, not what's most convenient for the provider, what's most convenient for us. I stopped seeing patients. I'm trained in neurology and psychiatry. So my patient population were people with brain injuries, either neurodegenerative brain injuries, stroke, less so trauma, mostly Alzheimer's and related problems like Parkinson's, et cetera. And I've got to tell you that in the Ontario healthcare system, before the pandemic, these patients had to come to my office. Generally, it was an adult daughter, maybe an elderly spouse who got them in the car, had to get them up early in the morning to meet the convenience of my schedule in the clinic. They had to get them to Baycrest on time for the clinic. Otherwise, I'd get all backed up and I'd get irritable. And then again, they had to wait, and then they had to go home. And if it's an adult daughter who's also working, she has to blow at least a half a day to go get her mother, make sure her mother's up and dressed, ready for the doctor's appointment. If her mother has one of these neurological illnesses, it takes a lot of time to get her in the car, get her out of the car, get her up to the clinic, get a wheelchair. It's a half a day of time to see a doctor for a 20 to 30-minute visit. This is incredibly wasteful and incredibly non-patient friendly or centric. Increasingly, we just won't tolerate that as patients or as family members. We've got to transform this. During the pandemic, these same patients needed to be seen, but we had to rapidly transform the clinic visit into a virtual care delivery. And we've found that we can deliver the same quality care more cost effectively, and that adult daughter doesn't have to miss a half a day of work and get her mother schlepped into the car to get her up to Baycrest. Yes, we do need the daughter with her mother when her mother's on the computer to be able to log on and do all of that, or on the iPad, or we need a home health aide that the family may have already engaged, because many of these older adults have trouble with the technology interface, which we're going to talk about. But by and large, I can tell you that the pandemic has exponentially transformed not only how we're delivering healthcare to ambulatory populations or outpatients now, but it's here to stay. No doubt about it. I mentioned this before, so we don't belabor it. We as healthcare providers will inform the patient's decision-making, but the decisions will be the patient's. And patients are now being informed not only by us as healthcare providers, but they're being informed by the internet, right, by Googling. I had an experience. I'm watching the clock. I think we'll have plenty of time for conversation, but I'll give you my healthcare experience. So I had to see a specialist. I had some unusual sort of pulmonary problem, and I had to see a specialist. And ultimately, once the specialist told me what the differential diagnosis was before he had established the firm diagnosis and I could be treated, I went on the internet and I read everything I possibly could about what these different diagnoses mean, what the treatments could be, what the prognosis is, meaning the future. And I did that not because I'm a doctor. I did that because I was a patient. And so you're as likely to do this if you're not physicians as I am as a physician. I might go to websites that you might not think of as sources of information, but I was reading everything by Googling. And we're going to get to that because that's going to be a significant part of the future in terms of how we interact with our patients. They're becoming as informed, sometimes more informed than their doctors about what's out there in terms of new treatments, et cetera, particularly doctors of my vintage that have a hard time keeping up sometimes with all of the literature because it's coming so fast and furious through so many different information sources. So I think increasingly, again, patients are going to be so much more active in clinical decision-making. They're going to be the drivers here. We're going to do our best as healthcare providers to inform them, help them to make what we believe based on our experience, our training is the best decision. But at the end of the day, it's clearly going to be their decision. They are not going to be nearly as passive as prior generations of patients have been. And again, I've been belaboring this, but it's a trend that's here to stay. Definitely a consumer-driven expectation of easier access to healthcare, better coordination among the different healthcare providers, and demonstrable value. If a daughter is going to lose a half a day of work to get her mother to the doctor, we're going to have to convince her that 2/3 or 3/4 of that was not wasted time. All right. Now, an allied concept with a consumer mindset being established in patients' minds is also the retailization of healthcare. I will draw your attention to the top right quadrant. I literally just took a picture of this off the computer a couple of days ago when I was reading the New York Times. So this is just a few days old. Some of you who read the New York Times may have seen this article. But the trend to try to deliver healthcare services in the most convenient place possible for a consumer mindset of a patient has now been established in different retail outlets with mixed success. So pharmacies is where it's been most successful. So pharmacies, I'm sure you've experienced this when you've gone to Shoppers or Rexall, wherever you go for your pharmacy, that there's definitely mission creep. And the pharmacies are starting to offer a broader and broader portfolio of healthcare related services. You most certainly don't just go to a pharmacy anymore for the retail part of the pharmacy or to pick up your prescription. The pharmacies are measuring your blood pressure, they're measuring your blood glucose, they're going to soon be doing eye exams, ear exams, and in fact, they've been pushing to be able to prescribe. So I think that the role of the pharmacy is expanding because it's being viewed as both improving accessibility to healthcare services. Of course, it's in the best interest of the pharmacists themselves from an economic perspective, but it's also targeted as consumer friendly. When I go to the pharmacy, I can get several things done at the same time. Not only am I picking up my metformin or my insulin, but I'm also having my blood sugar checked. Or I'm having somebody look in the back of my eyes at my retina to make sure I'm not showing early signs of diabetic retinopathy. Or I'm having a nurse practitioner or somebody look at my lower legs to make sure I'm not showing some of the changes in the lower extremities that I'm at risk for if I have diabetes. If I'm getting if I'm going to the pharmacy to get my congestive heart failure medicine, I'd like nothing better than a nurse there or a suitably trained professional to take a look at the edema, the swelling that I have in my lower legs, because that could be an indicator that my congestive heart failure is getting worse. And this is way more convenient for me than having to schlep to an ambulatory clinic at Mount Sinai Hospital to get the same thing done on a separate visit from when I'm at Rexall or at Shoppers Drug Mart. So I think that is definitely a trend that's here, and it's going to grow in impact. The other is the retailization, including not only a pharmacy, which is maybe a more logical place, but in large retail outlets like Target, Walmart, Sam's Club. You know what all these stores are. I can tell you, and I think this is going to come to Canada. It'll be connected in some logical way to the public health system, but because it's going to improve access and it's going to be consumer friendly, I believe that this ultimately is going to take root for those reasons. Of course, it's going to have to be managed very carefully, and that's something we're going to talk about in just a few minutes here. But my mother gets her eye exams, and she gets her ear exams, and she gets her hearing aids, and she gets her glasses, and she gets her prescriptions filled and her blood pressure checked, not at the doctor's office, not at the hospital, but at Costco. So, and she buys all of her ancillary things that she needs at Costco. She's 87 years old. So if she's venturing out of the house, it is unbelievably convenient to her to go for one-stop shopping and get everything done in one place in one time, because it's hard for her to get in the car and drive to different places throughout the day. And I don't want her to be driving that much. So if she can make one trip with the car to one place and get all of these needs met, including buying, her barbecue chicken at Costco, which I'd rather her not buy for health reasons. But if she'll buy all her stuff on one trip to Costco, including at times she'll go to the Costco version of LCBO because she lives in Florida. That I'm not thrilled with either. But the reality is she can get it all done on one trip. And my goodness, is that convenient as opposed to getting in and out of the car 7 times a day for an older person. Is very hard. Maybe it's okay for like my 30-year-old son, but it's not okay for my 88-year-old mother. So I think just this convenience factor, in fact, I'm showing you in the right lower quadrant as well, the development of health clinics in supermarkets, because that's another place that an older person wants to go to. And it's not so great that every older person can get all their groceries delivered at home. We want older people to be active. We want them to get out of their apartments or their homes if they're capable. We want them to be stimulated by walking around the grocery store, perhaps not during a pandemic. And we want them to be able to make choice like that and not be glued to the telephone or to the computer monitor to get all their needs met. The physical activity of holding on to the cart and walking through the grocery store is good physical exercise for a lot of older people that otherwise wouldn't have it. But the more the grocery store then, as a desired destination, a required destination, can serve other needs, the better. So again, this whole trend towards retail outlets satisfying more needs than just selling you something in their store that historically was their brand identity is changing dramatically. All right, now let's talk about emerging technologies. This is where I'm going to largely finish. And then we're going to have a good hour, I think, if we go to the full 4 o'clock, for you to respond to some of this and for me to address your questions or concerns. So let's talk about now, where does technology fit in all of this? And where is this potentially a good thing and maybe not such a good thing? Well, I think that you probably, I would imagine almost everybody listening to this talk has already experienced virtual healthcare. Right now, I'm not on gallery view, so I can see all my slides, so I can't see you put up your hands. When we get to the Q&A, we can do that. But I would imagine some, if not all of you, have now already had an experience with virtual care, perhaps provoked by the pandemic. I don't know. But virtual care, as I keep saying, is here to stay, and it's evolving. So, certainly you're familiar with, sitting in front of an iPad or a laptop or desktop computer and accessing virtual healthcare that way. I think that increasingly we're going to look for a convergence of technologies so that perhaps one platform can support virtual care as well as your other technological needs. That's why I showed you the picture of the woman in the bottom right-hand corner. This is a platform that we're working with Baycrest, with TELUS, and with hardware manufacturers where instead of having to go to your laptop or your desktop computer in order to access healthcare and then go to your television to watch Netflix, it's all going to be delivered, if possible, through your big television. And the advantage of that is the screen's much bigger, the resolution is bigger, and older people have more experience interacting with their television on an ongoing basis than their computers. For many of them, they just find the TV, as hard as it is, they still find the TV easier. And the new platforms for engagement with the television gets beyond entertainment and can support virtual healthcare delivery. So I think we're going to see more experimentation with the television and flat panel TVs being able to accomplish a lot more than solely their present function, which is getting the news and being entertained. The other thing that you're going to see more of is virtual healthcare that's delivered on your smartphone, not only in terms of a conventional pre-scheduled office visit, but healthcare systems that are looking for cost-effective interventions are going to see that sometimes if a patient has to wait to talk to a healthcare professional, they can then deteriorate, and you're not able to spot a change in their status fast enough. And so I think we're going to start to see much more on-demand access to healthcare, particularly in primary care. And so some of the easier way to do this is going to be through mobile technologies like your smartphone, to the extent that the resolution will be adequate for you and your healthcare professional, nurse, or whoever it is to be able to engage. So on-demand medical care right now is sort of seen more in private pay systems, but it's going to come to Canada. It's going to take root, and it will be adopted as a methodology by the next version of a healthcare delivery in Ontario. And you can see, as well in the bottom left-hand corner that already you can register for virtual healthcare services. What's being worked on right now is how these virtual healthcare services can be delivered across provincial borders and even across international borders, so that healthcare providers, particularly radiologists, pathologists who are in short supply in Canada, who might be in India, might be in the United States, might be elsewhere, can help support your Canadian doctors' healthcare delivery to you, so we don't have to wait 5 days for a radiologist to review your chest X-ray. We can get a contracted physician who's well-trained in another jurisdiction, whether it's another province or another country, who can provide that kind of consultation to your Canadian-based primary care doctor. So I think until we scale up and have adequate provider capacity, we're going to see more use of technology to get us connected to other healthcare providers that can help support our local efforts. Okay, there are other technologies that we're not going to have time to get into all of them that are driving the future of healthcare. Certainly to be able to deliver remote healthcare, both when we visit patients physically in their homes or we have to monitor them from afar. We medical professionals need portable devices to enable all of this. We need health sensors for our patients. These sensors don't necessarily have to be sensors that the patient wears. In fact, we're going to talk about this in a few minutes. Older patients, by their nature, are resistant to wearing health sensors. We have a very hard time just getting older adults to wear the fall protection bracelets, where their loved ones or perhaps a professional can be alerted if they fall because of the bracelet or necklace they're wearing. And so we are still trying to develop health sensors that are less intrusive, less obvious. But the reality is that that the sensors for health monitoring, some of them may have to be physically on the patient, but increasingly with the emergence of wireless technologies and smart homes, which I'm going to show you in a moment, these sensors will increasingly be outside the body of the patient. Of course, that's going to be setting dependent. When you venture out of your house, there's going to have to be sensors that are on your body or in your clothes at some point under your skin that will not be intrusive and will not remind people around you that you're an elderly person who needs to have a health sensor. And that's another thing about our sector, which I'll just mention as an aside. Older people don't like using canes. Older adults certainly don't like using walkers. They may recognize the necessity of the cane. They may recognize the necessity of the walker. They may recognize the necessity of having the pendant around their neck, okay, should they fall or have an emergency that they have to press. But quite frankly, all of these devices, which represent an approach to supportive technologies, are decades old. The walker today looks like the walker 20 years ago. The cane today looks like the cane 100 years ago. And it's a reminder, particularly for us narcissistic baby boomers, that we're showing the world that we're getting older, okay, and that we have special needs, that we're not quite who we used to be. And it's clear that baby boomers, our cohort attitudes are such as we don't like people to see that part of ourselves. And when we have to use a walker, it's reminding everybody around us, strangers as well as our loved ones, of our frailty. And we don't like it in front of our family members, and we most certainly don't like it in front of strangers. And that's why we see when to a doctor, it seems so, it's so crazy. Like, please, Mrs. Smith, use your walker when you go to the grocery store, because otherwise you're at risk of falling. And she won't do it because she doesn't want people to see her with a walker. And of course, in a grocery store, it's particularly difficult. So she's got the card at least. But I think that in the future, we've got to develop these assistive and supportive aids that are not so remindful that this is a frail older person. And I think we have the capability of doing it, and now's the time. All right, I'm going off on a tangent. We're going to talk in a moment about the Internet of Things as it pertains to healthcare and artificial intelligence, et cetera. Robotics clearly has taken root in the acute care setting for many surgical procedures. Okay, I think I'm starting to get a little feedback again. So if anybody who's unmuted can mute, that would be helpful. I'll give it another try. Okay, that's good. So robotics are being used right now live in operating rooms in all of the major hospitals in Canada. And remote robotics are now coming alive, where a surgeon can be outside of the hospital but perform the operation anyway through remote technology, so remote robotics. So if you have a very sophisticated surgery that needs to be done, and there's not that many doctors that know how to do it, I'll make something up. A heart transplant that could be done with a robotic Da Vinci system. But the wait list for a doctor in Toronto to do that procedure is 6 months, and you can't wait 6 months. But there's an available doctor in Vancouver who also has been trained on this technology, and it's in your best interest. Then that doctor in Vancouver can do the surgery. And he can do it remote, she can do it remotely. So those systems are coming online. That will also help improve access to high risk, very specialized procedures where our wait lists are totally unacceptable. And who knows, maybe it'll be a surgeon who's contracted at the Mayo Clinic, who's got the time, who's completed fellowship training, has got the time and can do this, and then we'll leave it up to the patient. You know, these are the risks if you wait 6 months to have it done by the doctor here in Toronto at the Toronto General, or we can have it done in 6 weeks which would avoid all kinds of long-term complications. But understand this is going to be done remotely through robotics. So, and the patient will be presented with those kind of alternatives. Virtual and augmented reality is also here to stay in healthcare delivery. Again, we can talk about that later if it's of interest. And clearly, artificial intelligence systems for diagnosing and clinical decision-making are growing. There's still quite a ways to go, but this will be a part of the future. Telemedicine, hospital redesign, we've already talked about. Some of you, I would imagine, depending on your professional backgrounds, are far more expert than I am on the application of precision medicine and pharmacogenomics. There will become a day where organs will be man-made. Parts of organs certainly will be man-made. I think that in my field, we're very interested in brain-computer interfaces. We're already implanting devices in people's brains and in their bodies. We've been implanting pacemakers for years for the cardiovascular system. We're implanting brain pacemakers now for certain conditions like Parkinson's disease or essential tremor or dystonia. And there's the opportunity to plant devices in the body right now, like to stimulate the vagal nerve for people who have depression. And there are going to be devices inside the body that go way beyond what I've just touched on, that are going to take advantage of emerging trends in nanotechnology. And again, I would imagine there may be some bioengineers in the audience today who know so much more about any of this than me, but I'm trying to just survey the landscape at probably a ridiculously high altitude here. In my field, specifically in aging and in congregate care settings, we're already testing the effectiveness of robotic companions, entertainment and leisure systems that involve virtual and augmented reality. We have found these systems to be particularly helpful in the care of people living with dementia in nursing homes who can get very anxious. They can sometimes, due to their illness, get combative when we try to care for them. They can get bored and restless, wander into somebody else's room. That can lead to an altercation. And so what we find is that virtual and augmented reality systems can help such people get out of the nursing home, experience the world outside the nursing home, and also get calm, be relaxed, and enjoy some recreation. So these systems are here to stay. At our Center for Aging and Brain Health Innovation, we're testing some of the most advanced systems in this area for older adults. In a network of beta test sites across the United States and Canada, we're evaluating their effectiveness. In Asia, and particularly in Japan, there's a lot of work being done on using robotic physical care assistants. You can see a little picture of that here, where we're finding less injuries in transferring patients out of bed into a wheelchair than when we do a one or two person lift using a mechanical lift at the bedside. So the robots seem to be safer than a human-directed mechanical lift. Again, these are very expensive, these systems. It's going to be very hard to scale them, but they likely are going to become a part of the technology that will be used in acute, in settings like congregate care, like nursing homes. I don't know whether they will ever reach sufficient cost where we can scale them into people's homes. And of course, they need to be supervised still. But we are evaluating the cost effectiveness and the safety of these devices now at Baycrest, as well as other beta test sites that are part of our center. Smart home appliances we're going to talk about in a moment. Smart beds, walkers, canes, walkers and canes that can see in front of you and then provide you with tactile or auditory feedback, whether you're approaching a hazard or you're walking in the wrong direction. So interactive walkers and canes, smart beds that are measuring your degree of movement, how well you're sleeping, measuring a bunch of biometric data, your blood pressure, et cetera, the status of a pressure ulcer or pressure skin wound, beds that are enabled with technology to provide important health information. What you see in the bottom right hand is a system that we've been using at Baycrest, largely for people in their homes in the community. It's a smart medication delivery device. A voice will say, Doris, it's now time for your afternoon medications. Come on over. Doris, how's your day going? What have you been busy doing? And it's a robot that interacts with Doris, but then says, okay, Doris, did you get your water so you can take your pill? which prompts her to go to the kitchen, get her glass of water, and then says, Doris, where are you? Because it can see her. Doris, where are you? And then when Doris gets back in her seat, the robot then says, Doris, okay, you ready to take your pills? She says, yes, I am. And then out pop the pills, okay, in the bottom of the robot. And she takes the pills, and in front of the robot, she takes the pills. So we can see that she actually did self-administer. And then these data are collected, and they can be fed to whoever needs to be monitoring whether Doris has been compliant with her medication. It can be a healthcare system, somebody working for a healthcare system, or it can be an adult daughter or somebody else who is looking after the welfare of this patient. Okay, and I'm going to finish now. I'm watching the clock. I'm going to finish now with how all of this comes together, leveraging big data, AI, and the Internet of Things, and the impact this is going to have on healthcare decision making. Well, I don't think that 10 years ago, I would have imagined that companies like Apple or Google or Amazon would see themselves as healthcare technology companies, but they most certainly do. And quite frankly, so do companies like TELUS and Rogers, and just too many to mention. They see tremendous opportunity here in terms of being part of healthcare delivery, not only in terms of hopefully enhancing value, but of course, creating value for their shareholders. It remains to be seen where this goes, but I'm going to review now in just the next minute or two what this is starting to look like. And then I'm going to raise some issues that I want us to address if we can. It'll be up to you in our Q&A and in some of our interactive dialogue. Well, I think the world of converging data into singular platforms is already here. I can't tell you, I've got plenty of older adult patients that are wearing wearables, and they've got Fitbits, they've got this particular Apple Watch, and why are consumer wearables here to stay? It's because they enable an integration of lifestyle, recreation, consumer activity, social life, behavior, biometrics into a single health surveillance and management platform. And so they provide so many different value added functions to the wearer. There's a reason why these devices have become so successful. Of course, when we start to talk about older adults, the major impediment right now for some older adults is the interface, right? That the buttons to type are very small. If you have visual acuity problems, it's hard to see what's on a screen the size of a watch. But technology developers are really working on improving those interfaces so that we older adults will be able to use these technologies more readily. And what we're finding is that when you converge the healthcare surveillance or the safety monitoring into a device that everybody else in the world uses anyway, like an Apple Watch, an older adult is much more accepting of it. Because when somebody sees an older adult look at their Apple Watch, it's not the same thing as seeing an older adult with a hearing aid. Okay, and maybe the Apple Watch or a watch like this will have the capability through some wireless connectivity to serve as your hearing aid. So it's actually augmenting your hearing, but nobody can see a hearing aid in your ears. And so I think, and for our memory patients, for our patients with mild memory problems, when an older person looks at their watch, which is providing them with a memory reminder, which is software we're presently working on with these technology developers, when an older person looks at their watch, nobody knows whether they're looking at the time or perhaps they're looking at their calendar or something else, but in fact, they're looking at a memory aid, which they don't want everybody to know about. But it looks natural because everybody looks at their watch, but for different reasons. Everybody gets the gist of where I'm going with this. So the more we can sort of normalize the interface that an older adult has with supportive technologies so that it doesn't stand out that this older adult has special needs, that's now obvious to everybody, the more that these technologies will be embraced and the more value they'll create for older adults. I think all of you have heard about the convergence of smart home technology, and it's really quite remarkable what's happening. And so we're testing a lot of these systems and they monitor your sleep at home, how active you are. They measure biometric data like your cardiogram, your oxygen level, your blood glucose, your electrolytes. They connect you to remote service platforms for healthcare intervention or an emergency. They automate your home so you don't have to make so many decisions on your air conditioning and your lighting and so many other things. They help an older adult with their energy management in their home. Of course, there are home security systems for older adults living in the community that are vulnerable. And there's monitoring to make sure that in the summer, the house or the apartment doesn't get too hot. In the winter, it's not too cold. And these things monitor how frequently the older person goes to the refrigerator, monitors how long a pot stays on a stove, monitors things like the use of the toilet. So if an older adult that's got diabetes or an older adult that has congestive heart failure that's diuresing too much or not diuresing or going to the bathroom to empty their bladder enough, this could be an early indicator that their health status is changing. And how else would we know this except to rely on self-report, which is helpful. But if we actually got data that told us, but let's say we had data that told us that when an older adult takes a shower in the last 3 weeks, it's taking them 100% longer to complete the shower task than it took a week or two before. Might that indicate that that older person is getting somewhat confused, right? Or something physical has happened with them? Why can't they complete a task like that in the same time they previously had? And what if the shower actually monitored that? Obviously not with video, but with sensors that say how long the water was on, how long the patient stayed in the shower. Those data might be helpful in understanding whether there could be a change in status. How long food remains in a refrigerator might be an indicator of, is that older person still going out to shop? Are they forgetting that their food in the refrigerator is getting old and could be dangerous, spoiled? So sensors for a lot of kind of information that we never imagined was possible to gather. So the point I'm making now is that in our lives, what's happening is that there are so many new sources of data that through the Internet of Things and the capabilities of big data collection and storage and the application then of artificial intelligence can help give us a much more detailed and complete picture of how is this person doing in their life. From what are they doing when they go to the pharmacy? Are they filling their prescriptions or not? What prescriptions are being filled? What are they buying in the retail pharmacy? If an older adult is buying more and more laxative, does that mean that they have a problem with constipation? And could that be a side effect of a medicine that otherwise the healthcare provider has no idea this is going on until, God forbid, this older person has a bowel obstruction and gets admitted to St. Mike's Hospital? You see the Fitbit providing health information. Obviously, health information comes from more conventional virtual healthcare delivery, as you can see with the woman with the laptop. You can see the smart home technologies that can also feed important information with regard to health status and well-being. You can see the guy in the bottom right engaging with a healthcare provider or perhaps Googling to find out more about their healthcare. We might get a sense of what's going on with someone's well-being by seeing what are they buying for food in the supermarket. If the patient who we've advised to be very careful about their diet is buying all kinds of food that's bad for their diabetes, does their diabetes doctor want to know this? And can they rely exclusively on what the patient tells them? If my doctor tells me, Bill, I want you to cut back on your scotch drinking, yet my doctor has access to data that I've given him permission to get that tells him how many bottles of Doers I bought at LCBO in the last 2 months, might that be of interest to my doctor when I do what most patients do and underrepresent how much alcohol I'm consuming? And then finally, remember I told you I had the experience of being of having some of this unusual lung condition. Well, I Googled everything I possibly could about this and started peppering my specialist with questions, and he didn't like it whatsoever. And when I told him that I went to my chart and looked at a recent CAT scan result, And I started questioning him on the findings on the CAT scan. He was also my vintage doctor, and he didn't like me asking questions about all this stuff that I Googled, because I Googled the CAT scan findings to make sure I understood what they meant. And he told me I was totally overinterpreting. I was being misinformed by Google. But the point is, Google is collecting a lot of information about me. And you all know that because you see the pop-ups, when you read the newspaper, you go to different websites. But if I'm Googling something about my lung condition because I want information about it, Googling is storing that search history. And that might lead them to conclude that I have this lung condition. Why else, or somebody close to me does, why else would I be Googling so much about this lung condition that I never Googled about before? That's personal health. That's an indirect proxy for personal health information. Healthcare will continue to be transformed by these innovations. I have little doubt about it. To what extent, I'm not sure. They're not all evenly weighted, but they are all important. And so now we're going to go into the question and answer period. And I'm planting some ideas in your mind that might want to anchor some of your thinking. Should we be concerned about how data is being gathered and how it could be potentially used with regard to a loss of privacy? Could these data, well-intentioned perhaps, the collection as it is and the analysis as it is, despite being well-intentioned, to what extent could these trends lead to exploitation and misuse? To what extent do these developments in virtual care and the supporting technologies diminish human connections, both in healthcare as well as obviously in social and recreational, and the other kinds of connections that we saw in Maslow's hierarchy are very important to us? Are we concerned when companies of the scale and size are collecting our data of monopolization? Are we concerned that with health systems coming together and being more fully integrated and controlling access and the delivery of healthcare to populations, that there'll be smaller numbers of independent healthcare providers because they're now being pulled together into large systems? And are we concerned about then the monopolization of healthcare delivery, not only the monopolization of data collection, analysis, and reporting? Are we concerned, particularly with the emergence of technologies, that there will not be equitable access, that those who can afford this technology will get access to it, those who can't won't, which is today's present reality. And then for those of you in the social sciences or economics, should we be concerned about the law of unintended consequences as we move forward with some, if not all, of these trends, and particularly for the economists, I guess, in the group, and with the extension to other social sciences, should we be concerned at all about moral hazard? Are we taking risks thinking that we're protected by others that we're really not so well protected by? And might we suffer the consequences of that? So I think that many of these changes are here to stay. What I tell my fellow healthcare providers or the payers, whether they're in China, whether in the United States or here, is we're going to have to respond to these changes. We're going to have to adapt to them. And it's those jurisdictions, those providers, those payers, those patients that are going to need to respond effectively to these changes. Otherwise, they're going to be left behind to their detriment. Well, I'm going to stop there because I know I covered a lot of ground. I did go over what I thought would be about 45 or 50 minutes.